Hi, it's Dr. Jonathan Terry. This is a preview of a presentation I'll be giving in February 2026 in Carlsbad, California at the Osteopathic Physicians and Surgeons of California Annual Conference. The title of this presentation is Integrating Mental Health and Well-Being, Acute Psychiatric Assessment and Management in Diverse Clinical Environments. Quick caveat is that the well-being piece is a bit of a remnant with the conference theme. However, this talk really is geared toward primary care and emergency medicine audience with how to assess patients psychiatrically in acute settings, especially for agitation and anxiety. My doctor's bag of disclosures when it went through the x-ray did not come up with anything other than perhaps I wish I had more to disclose. I will mention that I did have some fun creating the slides for this presentation where the content is mine, but I did have AI help me generate some of the images to make it a little bit more interesting for anyone who needs to sit and listen to something for an hour. In this presentation, we'll have 5 major learning objectives. First, we'll go through some definitions, defining acute agitation and its clinical features. Next, we're going to differentiate various causes of medical, psychiatric, and substance-induced causes of agitation, and we'll take a look at specific case scenarios. Next, we'll describe the rationale between choosing specific pharmacologic versus non-pharmacologic interventions, followed by justifying treatment choices in complex cases that may involve agitation, comorbid medical or substance use conditions. And finally, my favorite, perhaps most importantly, we'll be talking about communication and how to communicate with agitated patients in multidisciplinary teams in a way that promotes safety, empathy, and clarity. So let's talk about some definitions. Acute agitation is something that physicians look at not necessarily as the way that we might feel on Monday morning heading into work, but it really is a behavioral emergency. Agitation is a state of excessive psychomotor activity, often accompanied by increased tension and irritability. There's a continuum that I'll be talking about in the next slide that really progresses from mild anxiety all the way to violent aggression. It's important to note that agitation is a symptom. It's not a diagnosis. If a patient is agitated, it doesn't tell us why they're agitated or what to do about it. Clinical features of agitation can include motor symptoms such as pacing, fist clenching, or an inability to sit still. It may include verbal symptoms, speaking loudly, being argumentative, or using threatening language. But there's also autonomic symptoms that we might see on our vital signs or in a physical exam. The patient might be tachycardic, they might be tachypnic, and they could be sweating. And if these things are going on, it might indicate that this is a medical cause and not just somebody who's very upset with us. As I mentioned, there is a continuum with agitation, where most simple agitation can include those motor, verbal, and autonomic symptoms that I spoke about. But then when we move into aggression can be physical behavior such as throwing objects, punching walls, or self-striking. We'll often describe aggression as being something toward objects, perhaps to differentiate it from violence or threats of violence which are geared toward people. So if a patient is assaulting staff or threatening to assault staff, that takes us much further than just simple agitation, where now we have a violence risk and we really need to think about safety. It should come as no surprise to us that agitation can have multiple different causes, and in this next section we'll be taking a look at different causes of agitation and how they might play a role in our workup. Anytime a patient presents with agitation, we need to think about things in terms of at least these 3 major categories, which we'll go ahead and spell out a little bit further on the next slide. Medical is perhaps in a medical setting one of the most important things to work up. These can also be called organic causes of agitation. Key etiologies might include delirium, hypoglycemia, hypoxia, sepsis, thyrotoxicosis, CNS infection, or head trauma. Some of the red flags here are things like abnormal vitals, if it has a sudden onset. Also, if there's a person who has an age greater than 40 without a specific psychiatric history, if a person is disoriented, or if they have visual hallucinations. All of these should point to some underlying issue. The next thing potentially is substance or a toxic induced agitation. And this can be due to intoxication with things like stimulants or alcohol, or withdrawal from some of the downers, particularly from our GABAergic ones, such as alcohol and benzodiazepines. Red flags or clinical cues here, often overlapping with medical causes, can include changes in pupil size or symmetry. If there are track marks on the arms indicating perhaps injection or skin popping. Toxidrome signs such as sweating or tremors, and if they have a substance use disorders history. The third and final diagnosis or diagnostic area in the triad is psychiatric diagnoses. Now, as a psychiatrist, I bring this up last because if it is a primary psychiatric disorder causing the agitation, that should always be the diagnosis of exclusion, meaning that we've looked at medical disorders and or substance-related disorders as patients with psychiatric presenting chief complaints can also have medical or substance issues causing them to be agitated. So the takeaway here is to always rule out medical and substance causes before attributing agitation solely to a psychiatric etiology. Now, some of the psychiatric causes can include things like schizophrenia, bipolar mania, borderline personality disorder, PTSD, and some of the symptoms here that we might see could be auditory hallucinations, a history of a psychiatric disorder, especially if they have normal vitals or normal labs, and if the person is alert and oriented. That can indicate that we're not looking at a deliriogenic or an iatrogenic process, usually, but instead a primary psychiatric process. I like this slide visually because it breaks down those three categories that we spoke about. Medical conditions or delirium on the top right, intoxication of any number of things on the top left, and psychiatric conditions on the bottom left. And my favorite that kind of gets added to this is what we might call bad apples, people who are misbehaving to misbehave. And this might fall more into the category of sociopathy, not to be confused with psychopathy, but somebody who has some type of primary or secondary gain issue, and they might be agitated because of some other goal that's going on. However, before declaring really the bottom half of the slide, someone being a bad apple, not a diagnostic term, or behaving badly, or a psychiatric condition, again, it is the duty of the physician and the medical team to rule out any potential intoxication or medical conditions or delirium. When I'm doing consult liaison psychiatry in emergency rooms and on the units, I can't tell you the number of times that I am called for somebody who's agitated, who's tugging at their lines, who's being assaultive towards staff or their sitter or even family, or self-harming. And the primary issue is not psychiatric, even though the behavior certainly could be. Instead, what we often see is a deliriogenic process or perhaps a withdrawal of something that the patient was taking or prescribed, or an intoxication. So this really is a reminder again that the top conditions, the top left, the top right here, the intoxication, the medical conditions, delirium, are going to be our primary areas to rule out before thinking about the psychiatric conditions or that a patient really just is acting out with some type of intentionality or primary or secondary gain. If a patient does come in agitated, I think that the most important thing to know is how to do a good workup, because without a good workup, without an appropriate diagnosis, we really can't direct treatment to be appropriate for the patient. So these are in order of the things that I would consider doing for a patient and things that I do in my own practice when I'm evaluating a patient with agitation. Vital signs are, for lack of a better word, vital. If a patient has an abnormal temperature, if they have an abnormal pulse, respirations, or blood pressure, that can indicate, one, of course, some of those things can be associated with the agitation or anxiety, but particularly temperature, for example, if that corresponds with tachycardia, tachypnea, or hypertension, and those are not normal things to expect in this patient, that can indicate that something else is going on. Physical exam is critically important. No amount of agitation without an underlying cause is going to cause things like nystagmus. Likewise, dermatologic signs. We talked about track marks or potentially signs of substance use disorder. Again, not coming at this from a judgment perspective, but in wanting to take care of the patient and wanting to do things as safely as possible. Again, eye signs like miosis or mydriasis, anisocoria. Tremors can be very important to look at. Looking at the patient's general level of arousal can be important. Remembering that sometimes even patients, of course, we pay attention to a hyperactive delirium, but sometimes we will miss the hypoactive delirium if a patient is obtunded and not able to participate. Mental status exam is then critically important to describe the findings often that we see on that conversation or the physical exam. Components of a mental status exam might include things like the patient's mood and affect. In an agitated patient, those might be predictable. But we also want to pay attention to their speech. Are they able to connect thoughts in their thought process and have a linear or goal-oriented thought process? Or are they circumstantial? Are they tangential? Do they have thought blocking or derailment? What is their thought content? Is it based in reality, or is it based on perhaps responses to internal stimuli or perceptual disturbances? How is the patient's executive function? Do they understand why they came into whatever setting that you're in? and what the evaluation is for. Or is there some type of disorientation going on? Do they lack insight or judgment? These can all be very important things to assess, and again, really understanding that a good mental status exam and arguably a good neurologic exam are components of a thorough physical exam. History is also going to be important. On Friday night, I was evaluating a patient with chest pain who was behaving very unusually. The patient was having an NSTEMI at that time, and she was had a lot of kind of bizarre beliefs and alternating attention. Turns out that in addition to the NSTEMI that was going on, she had just been given Dilaudid, and she was having some arguably iatrogenic and deliriogenic effects of the Dilaudid. If a patient has a new onset severe headache or seizures, that could potentially indicate something going on like a mass effect or a brain bleed. We also want to pay attention to trauma, not necessarily trauma in the post-traumatic stress disorder or acute stress disorder categories, even though those could be helpful. But is this a person who came in from a motor vehicle accident? Do they have something that could have put their body or their physical integrity at risk? And now there might be something that is missing. Is this a patient who needs to be evaluated in a trauma setting or trauma bay? Medical history is also critically important here, right? Is this a patient who has, for example, an endocrine disorder of some type, thyroid disorder, diabetes, and is there, is a thyroid storm or hypoglycemia or hyperglycemia? All of these can be associated with altered mental status, which frequently, although not always, is associated with agitation. If available, lab studies can be so important. Now, I understand in outpatient settings and perhaps in many crisis stabilization settings, you might not have the same access that you might on an inpatient setting or in an emergency room. But if you're able to, the findings on one's physical exam and the findings in a mental status exam and perhaps a neurologic exam can lead us through different categories of areas that we might look at. For example, if a patient complains of significant headache or if they have new onset seizures, a head CT might be indicated. My medical students and residents refer to the CT scanner as the donut of truth, and I think there's something to be said for that. Chest X-ray can also be immensely helpful, right? If we remember that the most common causes of agitation or altered mental status, especially in the elderly, can be infectious. They can be identified perhaps through a chest X-ray or a urinalysis. General laboratory can include a CBC, which will tell us, of course, about factors such as infection, anemia, different factors there. A CMP can tell us if there are electrolyte disturbances that are going to different things, or if the patient perhaps has hepatic encephalopathy, which would take us down an entirely different route for treating that agitation than, say, an overdose of different drugs of abuse. Urinalysis we spoke about as an incredibly common part of the workup that I frequently see missed related to delirium and agitation. For medication levels, there are many different medications. Here I've named lithium, but this can apply to tricyclic antidepressants, many of the mood stabilizers, even blood thinners. We can have different ideas about how a patient's medication or iatrogenic causes could be influencing their agitation. Specialized screenings might and probably should include a tox screen, and even if a patient is in a controlled environment. For example, I oversee a number of correctional settings, and in these settings, even though in theory things should be locked, it doesn't come as a surprise, especially to a clinical audience, that contraband and drugs do find their ways even into the most locked settings. So it is reasonable to have an extended workup based upon your setting and at what is available to you there. TSH, B12, RPR can be very helpful. Sometimes neurosyphilis can present this way, and we do see some of that, especially in certain settings. Also, an EKG, lumbar puncture, and glucose check can all be informative. But again, so much of this is about going back to first year medical school, good physical exam, and being able to differentiate one's assessment and plan for what's going to be the next step to match the patient. We don't necessarily want to order every test in the book and hope we find something, but we want to guide our laboratory studies and diagnostic tests toward the patient in front of us and what they are showing us in terms of their symptoms. To highlight some of these topics, I have included a couple of different case presentations, and I'm going to come back to these case presentations a little bit later. Right now, these are for us to run through and think about what might be going on. So as I tell you about this 81-year-old female, think about what potentially might be causing her agitation and how the workup might be in this setting. So this is a patient who is either in, well, actually in her case, she's going to be in an internal medicine or a family medicine inpatient unit. And she's been admitted from a skilled nursing facility for urosepsis and urinary retention. She's on day 3 of her antibiotics, and I am thrilled to say that her shock and her acute kidney injury have much improved. But overnight, she did have increased confusion and agitation. Nursing called the doctor on call to say that she actually removed her Foley catheter, and she's been assaultive toward nursing staff, resulting in medications and soft restraints being applied. The applicant is also, not the applicant, the thinking of my workers' compensation hat here, the patient has also been describing threats of knocking out the staff and feeling bad for the mother of the doctor as you evaluate them, that you became a doctor, and very uncharacteristic behaviors for this patient. Let's think a little bit about potentially what could be going on, leading to that increased confusion and the acute agitation, and what might be causing her issues there, as well as how we might work that up. Let's run through a second case here, again, just to give you a hint to start thinking clinically what could be going on with this patient. This is another patient who is actually now on family medicine inpatient service. This is one who I was consulted on with my residents recently. And this is a patient who was admitted due to intractable pain and nausea secondary to nephrolithiasis. This is a patient who has well-controlled schizophrenia, and the current case is managed with as needed ondansetron, metoclopramide, ketorolac, and hydrocodone or acetaminophen. And overnight, the team was paged for acute agitation by the nurse. Again, this is a patient who, don't get too distracted by him having a history of schizophrenia. It's been well controlled, and actually, like many patients with schizophrenia, most people would not know that he had that unless they were to look at his medication list or have knowledge of his case. So we can think a little bit about what's going on with this case, and we'll come back to that in just a little bit. Now that we've had a chance to think diagnostically a little bit about patients who present with agitation and just how diverse and incredible these presentations are, I want to spend some time taking a look at the next pieces, which are really going to be how do we choose interventions, how do we justify the right treatment, and how do we communicate effectively with diverse patient populations in equally diverse settings. We were in sort of the subjective and objective parts, if you will, of our SOAP note, and we are now moving into our assessment and plan and trying to see what we do from here. One of the ways I'd like you to think about this again is really kind of a step-by-step process here. And the assessment, again, I intentionally started this presentation and took us back to medical school just a bit to remind you that the assessment is critical. If we have an agitated patient, again, except if there is a case of immediate and risk or violence, and we need to do something right away to keep people safe, getting a good diagnosis and a diagnostic workup is critical. So that's going to be our stage 1, really the assessment and triage part of it. Stage 2 is where the magic happens. This is when we begin with the therapeutic interventions. Now, you notice that verbal de-escalation is going to be one of the first things on my list. And that's in line with what we're going to talk about with some Project Beta and best evidence strategies in the coming slides. But verbal de-escalation really is going to be our strategy before psychopharmacological interventions. Again, the psychopharmacological interventions might be needed right away if there's an issue of safety. But if a patient is agitated and can be verbally de-escalated, and if you can build that therapeutic rapport, that's absolutely where we want to start. And of course, psychopharmacological interventions can include voluntary medication use. That is always going to be our first choice. And potentially involuntary chemical restraint, which might be a possibility in your setting based on the patient's clinical status and any potential legal guidelines about when medications can be administered on an involuntary basis. Now, of course, in many community settings, that won't be an option, but perhaps in hospital settings and emergency settings, it may be. Finally, as a last resort, we may consider patient seclusion, again, only if the patient is in a place of not being a risk to themselves. We don't want to expose them to further risk of potential self-harm. And physical restraints are going to be our absolute last resort, not just because that interferes with potential ethical issues and patient rights, but also physical restraints are with significant risk of patients harming themselves more if they are not more calm once the physical restraints are considered. One of the guidelines that I absolutely love, still actively teach, so this is from Project Beta, or the Best Practices in Evaluation and Treatment of Agitation. And this was from the American Association for Emergency Psychiatry, again from 2012, but it really does remain a great set of guidelines. And these domains that are here, each of these 10 domains, can be a lecture in itself, with opportunities to practice and build this out potentially as a training exercise for every level of training, because sometimes we, in almost every medical encounter, and certainly as a grading OSCEs and looking at different things as physicians, we don't always recall these things, often because of the stressors of the situation, or feeling rushed to do things, or wanting to find a solution right away. So certainly I do recognize, of course, some of this is ideal. It may not be always possible, but it is still worth a pause and a reflection that if one does have the setting and the space and the time and resources to pursue these 10 domains of de-escalation, it is a goal for patients who are agitated. So domains 1 through 5 are really focused on foundation and engagement with the patient. And personal space is really important, making sure not to block exits, ensuring safety, and maintaining really a 2 arms length distance if you can. Not being provocative, and that involves calm body language, making sure the hands are visible. Avoiding confrontation and humiliation. Many patients who are agitated would not wish to be that way if they could navigate their way out of it. That can also include sitting down if it's safe to do so, making eye contact, really wanting to be as non-threatening as possible. Establishing verbal contact is really important. So having one person interact, even if there's a team or approach. Introducing the self and orienting the patient and providing reassurance. Not immediately jumping into a string of questions and putting the patient potentially in a defensive stance, but really saying, hi, I'm Dr. Terry. I'm here to help you today. Tell me a little bit about what's going on. We want to be concise and use simple language, short sentences, allowing time to process and repeating if needed. Asking the patient, where are you? What hurts? Are you okay? How can I help? All of these things are going to be really important versus much more concise, versus much more elaborate phrasing or using medical jargon. We'll also want to focus on the patient's wants and feelings. Even if they're agitated, a lot of times they can make their needs known. It might be, I want to go home, or it might be, this hurts, make the pain go away, or it might be, I'm in withdrawal. And we want to actively listen and understand the patient's perspective and validate their feelings. Domains 6 through 10 move more toward collaboration and resolution. And the slide is intentionally very detailed, right? Because as we're looking at ways to address agitation, we want to emphasize this verbal de-escalation as best we can. So active listening is going to be so important, focusing on understanding and not just replying. A lot of active listening, if you need a shortcut to active listening, it might just be repeating and summarizing what the patient said to indicate that you heard them. Patient tells you, my pain is a 10 out of 10 and I need something right away. You can restate to them, I hear that you're hurting, and express an intent to help them. You can agree or agree to disagree. The goal is to find common ground. Avoid arguing whenever possible. Again, especially if the patient is in some state of delirium, arguing is going to be very little help to anyone, because you're not going to get them to agree with things that they can't understand at that moment. You can set clear limits where it's okay to disagree, but if yelling is happening or threatening, then we're going to need to do something differently. And framing it as it's the patient's choice for how we proceed, and asking them how they would like to proceed, and not threatening them that if you don't do this, you will, for example, get a shot or have to go into seclusion. We don't want to do that. We do want to offer choices, and a menu of choices is reasonable. Okay, would you like to do A or B? And providing some hope that, again, that common goal, that common agreement is we're going to find a resolution, and focusing on the positive outcomes. I understand you'd like to go home. I understand you're hungry. I understand you're upset. Can I help you get through that? And then once all is done, this is something that I think is often missed in our clinical settings, is seeing if there's an opportunity for debrief, to come back and to both the patient and the staff and discuss the event, the improvements, and where are people getting stuck? Were there emotional reactions? Is there anything else that needs to happen so that we can make things best for this patient, but also with our care teams, because we'll be on those teams again tomorrow. And we want to build a sense of trust even in situations that are extremely stressful. Of course, as a psychiatrist, I am often thinking and often being consulted about pharmacologic intervention. And the goal of medication here is often to calm the patient to a state where they can participate in care, but not to knock them out or induce sleep or unconsciousness. Many of us are trained with what we might have called the B52, involving haloperidol, lorazepam, and diphenhydramine. And often the goal of this was to put a patient to short term to get them to sleep, so that you could get some peace back for the patient and the team. And again, the problem with that is myriad, which we could explore in a lot of detail. But it also means that that's a longer time potentially until the underlying issues are resolved and the patient has treatment. So again, I want to emphasize that if medications are used, a goal should be that we get to a place of meaningful participation and not necessarily unconsciousness. Some of the language that I was trained on and that still persists very much so in medical terminology is this idea of chemical restraints. And I'd like us to move away from that as best we can. And part of the reason for that is that medications really are not chemical restraints. Instead, a chemical restraint implies that we're taking away the patient's liberty, or perhaps allowing them to participate less, and it might even be for staff convenience. This idea of restraints, it can be derogatory, it can add stigma, and really, especially going back to our patient from the skilled nursing facility with urosepsis, restraining her gives a different idea than we're going to solve the underlying problem. So as much as possible, we certainly instead want to think about how can we involve the patient in decisions for if we are going to use pharmacologic mechanisms. Can they participate in an informed consent? Asking the patient, would you like something to calm down? Would you like something so that maybe the thoughts aren't coming as rapidly? Would you like something that might help you? Because the real way to look at this is that whatever we're doing is going to help the patient. And I think that's a good reframe as well, is are we medicating the patient for the staff, or are we medicating the patient for the patient? So our treatment goals should really be to reduce agitation, to reduce these dangerous behaviors, perhaps the racing thoughts, hyperactivity, to help the person feel more relaxed and calm so that they can participate more, and potentially to minimize side effects, not only of the treatment that we're using, but is the reason that they're agitated in the first place due to medication side effects. Now, medication in general, there are some that are FDA approved for indications such as acute agitation, or it can also meet community standards. I should have mentioned, perhaps not a disclosure, but a disclaimer, is that a lot of psychiatric practice and a lot of emergency practice may not be FDA approved, but it should match a community standard of care. For example, it would be highly irregular to offer fentanyl and Versed in an emergency room for an agitated patient, even though it would be highly effective with addressing that agitation in a very rapid way. Now, Project Beta does give us some guidelines about if medication is required, right? There's a lot of places we can go without medication being required, but if medication is required, there is a thought process that we need to go through. And you'll notice here that it really, again, depends on having the right diagnosis. So I think one of the critical rule-outs here is there an intoxication or not? And if it's a CNS depressant, such as alcohol or benzodiazepine, and withdrawal is suspected, then we're going to use things like a CIWA protocol, perhaps if your facility has one, to use benzodiazepines, preferably oral, first, to manage that withdrawal and to keep the patient safe from what could be a life-threatening issue. Now, if alcohol or benzodiazepine is not suspected, then most of the time, at least for many of the categories of agitation and psychosis, we're going to be using different antipsychotic medications. Here, SGA refers to an atypical or second-generation antipsychotic, whereas a first-generation antipsychotic, or an FGA, is mentioned here as well. Each one of these topics is, again, a presentation in itself, so my takeaway for you here is really to think about what's going on with the patient. Do they have an alcohol or benzodiazepine withdrawal or intoxication? If so, we treat it through the GABA mechanisms with benzodiazepines. Likewise, if they have a CNS stimulant intoxication, such as meth or cocaine, Benzodiazepines can be a primary mechanism here, using inhibitory mechanisms through neurotransmitters, although certainly antipsychotics can be considered. If the patient does have intoxication with a CNS depressant, then we're going to potentially consider antipsychotics, as we do not want the patient to have further respiratory depression. That's kind of in this greenish box here, the second from the right. That's one of the reasons as well why we might consider first-generation antipsychotics before our second-generation antipsychotics, as there is at least a theoretical risk of further respiratory depression with our second-generation antipsychotics. First-generation antipsychotics are highly potent in their dopamine antagonism. They're more selective, and they have very little effect on other receptors that will control, perhaps, say, wakefulness and blood pressure. So they treat the agitation and psychosis, but generally will leave the patient awake and breathing on their own, versus, say, second-generation antipsychotics that hit a wide range of receptors that powerfully block histamine causing sedation, alpha-1 adrenergic receptors causing hypotension, and muscarinic receptors that may cause further confusion or delirium. So if you give a sedating second-generation antipsychotic like olanzapine or quetiapine to a patient who is already intoxicated with something that is central nervous system depressant, you may see further CNS and respiratory depression, which we, of course, would very much like to avoid if we can. As you all have access to the slides, this is another way potentially to look at how we might structure medication dosing. Benzodiazepines might be considered for undifferentiated causes that don't have psychosis or delirium, remembering that if a patient does have CNS depression due to delirium or intoxication, the benzodiazepines are actually probably going to cause more problems, more sedation, more risk of respiratory depression. Typical antipsychotics can be considered second line if the patient has psychotic symptoms only. A lot of times we like to go with our atypical or second generation antipsychotics. But if there is any issue with CNS depression here, again, we for the most part want to avoid our atypical or second generation antipsychotics, at least as first line agents, because we do not want to worsen respiratory or CNS depression. A way to think about this is our second generation antipsychotics that we know, olanzapine, quetiapine, etc., they can be very sedating, and if somebody's at risk of sedation, we don't necessarily want to sedate them more or give them risk of changes to their vital signs, further complicating the case. Another summary slide here from Project Beta is that if a patient can take a medication orally, we prefer that for so many reasons, not the least of which is patient autonomy and patient safety, avoiding the use of sharps with agitated people if we don't have to. Voluntary acceptance is always better if we can, and realistically, oral route can control agitation within minutes. People often perceive, yes, the parental route is faster, it gets in, all bypasses first pass metabolism, all these different things, but remembering that it takes more time to prepare, you may need to restrain a person to give it, there's a risk of needle stick injuries. In my practice, I really try to avoid giving injections if helpful or if possible, because our goal here again is patient participation, calming, and finding ethical, humane, and beneficial ways to pursue that. If we can reduce needle stick injuries and less violence, those are also a big part of what we do. We'll remember, and I'll reiterate, that medications are not chemical restraints. Medications ideally should be FDA approved, and if not, they shouldn't match the community standard of care. And going back several slides, even though I've been talking about medications a fair bit here, we want to combine them with de-escalation techniques, particularly verbal de-escalation, when we can make that happen. So let's go back to our cases. Our first case, we might recall, was that 81-year-old female who had been transferred from the skilled nursing facility due to urosepsis and urinary retention. The patient had shock and acute kidney injury that had improved on antibiotics, but day 3 of hospitalization overnight, there was acute agitation, she was confused, she removed her Foley catheter and was assaultive of staff. This should look very clearly, almost like a textbook case of hyperactive delirium. And in this case, we certainly want to avoid benzodiazepines if we can. Why? Because benzodiazepines, certainly they don't meet the Beer criteria for an 81-year-old female, but they also may worsen delirium. We also might consider a first-generation antipsychotic, even though we mostly would avoid these in elderly patients. A small dose of an antipsychotic, a typical antipsychotic, such as haloperidol, can be very, very effective. Even like 1.25 milligrams IV can really help to lessen the delirium here, or lessen the behavioral consequences of the delirium, while we are continuing to work with the patient to see, do we have the correct antibiotic here? Do we have urine cultures back? What's going on? And is there some type of additional infection that we need to look at? Risperidone is also a consideration if she is willing to take by mouth medications. Risperidone is a second-generation antipsychotic, but it tends to be one of the more typical antipsychotics in that it is has a high affinity for D2 receptors and is a little bit cleaner than some of the newer antipsychotic medications as a possibility. Oral haloperidol is also a consideration here. Again, we want to go with a low dose of medication here and really just be mindful of the patient here. We'd also want to be mindful of any QTC prolongation, which would be a greater risk with the haloperidol than it would be with risperidone. Now, if we were to look at our 22-year-old male, who we remember had a history of well-controlled schizophrenia until he was admitted for this intractable pain and nausea due to having a kidney stone. He had been managed with ondansetron, metoclopramide, ketorolac, and hydrocodone acetaminophen, and the team was paged for acute agitation by the nurse. Now, a consideration here is that this patient might have akathisia. Why might he have akathisia? Well, we are using medications that have some dopaminergic effect. There's a possibility that his antipsychotic was interrupted during the admission. And in particularly, the antipsychotic combined with the metoclopramide, they both have some dopamine blocking activity, and that may prolong the QTC interval. So this is a patient who arguably has akathisia. So one of our goals might be to decrease the dopamine antagonist. Can we get by without the metoclopramide? And can we treat this patient's akathisia? This is one of my favorite things to look at in terms of making sure that learners really understand antipsychotic and dopaminergic side effects, because the treatment for akathisia is not more antipsychotic, and it's often not anticholinergics, even though that is something that can be considered as a subsequent agent. But really the propranolol or a beta blocker is going to be one of the first agents that we're going to look at here to address this akathisia and this restlessness here that's being caused in this case. Now there is some complexity to cases, right? And being mindful about what treatment we pick. So we've spoken a little bit, for example, about the elderly patient. And here we want to be mindful of a potential paradoxical reaction to benzodiazepines. Could benzodiazepines, if administered, worsen CNS or respiratory depression? Could they worsen delirium? Absolutely. And so we do want to avoid benzodiazepines. Antipsychotics likewise do have a black box warning in the United States about increased mortality in elderly patients. So if informed consent is possible from a patient or a caregiver, we do want to present it as saying, hey, this is something that might help you to calm down. It's something we're going to need to monitor very closely. What you don't want to do with antipsychotics is sort of that set it and forget it, where once the patient is calm, that doesn't mean that the underlying issue has been resolved, right? We really want to look for what's causing potential delirium and agitation, and really look at the overall patient's wellness and what's best for them. So really what we want to do with elderly patients is this start low and go slow idea, where a quarter to half of the standard dose can be considered. And often, but not always, we might consider a second generation antipsychotic if the pure symptoms are more of a psychotic agitation or delirium, versus if there is some type of central nervous system depression or respiratory depression where we'd want to avoid the second generation antipsychotics. Now, a pregnant patient might have a different set of considerations. We certainly want to look at teratogenicity and maternal fetal safety, as well as any potential risks from trauma, right? Certainly voluntary administration of medications is ideal in these cases. Haloperidol and diphenhydramine have the most safety data, probably just because these medications have been around forever with pregnant patients. But we certainly do want to avoid benzodiazepines, and it would be nice to really avoid polypharmacy in these cases if we can. Now, if a patient does have a prolonged QTC, we'll say, greater than 500 milliseconds, we're mostly going to want to avoid our first-generation antipsychotics, where benzodiazepines might be considered, or even a low dose. Olanzapine, quetiapine are fine from the second-generation category. We want to avoid ziprasidone or Geodon, as that medication is associated, at least in the literature, with a little bit more QTC prolongation risk. Now, I think it is critically important for us to, as we're talking about agitation and treatment for agitation, to include a reminder about implicit bias and health disparities, not just because it was a requirement of this presentation from our accreditors, but also as something that we really do need to pay attention to. These are just a handful of recent studies that I was able to pull up in PubMed with very simple search terms, and there were hundreds of cases of published reports demonstrating that people of color are more likely to be restrained in emergency department settings compared with other patients, with some barriers that many of the studies were based at a single site or healthcare system limiting their generalizability. Now, in looking at these studies, physical restraint in general is becoming increasingly less common, occurring in less than 1% of encounters. But adult Black patients did experience a significantly higher risk of physical restraint in emergency settings compared with other racial groups. Hispanic patients, interestingly, were less likely to be restrained compared with non-Hispanic patients. But this observation was also skewed in some of the data that was looking at. I think the important thing here, again, is to note that there is implicit bias and there are racial and ethnic factors that go into health team decisions for when restraint is implied. Arguably, further work is necessary, including qualitative studies, perhaps looking at mechanisms of these biases at the interpersonal, institutional, and structural levels, along with ongoing attention to health disparities. This is a much bigger topic than this talk is made for, but it is something that we need to be mindful of in making sure that we are treating our patients based on their presentations and not necessarily their cultural or ethnic backgrounds, unless that is somehow immediately relevant to the case in front of us. So this is almost all of the learning objectives that we have covered today. We started with definitions of acute agitation and the continuum of clinical features that can be a part of agitation. We differentiated between medical, substance-induced, and finally, as a diagnosis of exclusion, psychiatric causes for agitation. We took a look at the rationale behind choosing specific pharmacologic versus non-pharmacologic interventions, with an emphasis that non-pharmacologic interventions should be used in every setting, and pharmacologic interventions might be considered in some only after the verbal de-escalation has been attempted and integrated. We should also justify our treatment choices in complex cases involving agitation and comorbid medical or substance use conditions, and communicating with agitated patients and multidisciplinary teams in a way that promotes empathy and clarity. If there was a goal to make a training for staff, I do think that the Project Beta slide where I had those 10 general categories of verbal de-escalation can be immediately helpful, as the pharmacology actually is simple once one knows the diagnosis, but practicing and changing the way that we communicate with patients and being aware of any potential implicit biases amongst ourselves and our systems is something that we arguably all need to pay some more attention to. Finally, as I appreciate that this is a conference focused on wellness and well-being, and we are presenting amongst an audience of primarily osteopathic physicians, I want to remind you of the osteopathic approach, even as we're looking at cases of agitation. As osteopathic physicians, we need to remember our goals of holistic assessment, viewing the patient as a unity of body, mind, and spirit, and that agitation is multifactorial. Maybe it's a response to pain, maybe it's about fear or metabolic distress, conscious or not, and that's not just bad behavior. Empathy is something that we should never forget, and it's so important to put empathy first, approaching our patients in a non-judgmental way and asking them for help to understand what's upsetting them. This aligns with our osteopathic tenet involving patient partnership. Finally, safety needs to be a system of care in itself. We want to protect the patient from self-harm and staff from injury as a primary holistic goal of us as osteopathic physicians. Safety allows us to take a step back, to diagnose and to look at a patient holistically and what's going to be best for them. I have included my references here. And this concludes the discussion on integrating mental health and well-being, acute psychiatric assessment and management in diverse clinical environments. Again, any component or even learning objective in this talk could be a discussion all in itself, but for general CME purposes and to remind us about different things we might think about with agitated patients, I hope that this has been helpful. Thank you for listening.